My first situation in physiotherapy took me a few months to get to. I finished, I guess it was November of 1968, and we graduated. And on our graduation certificate, we actually had to put our thumbprints. We had a policeman come to the school and take our thumbprints and carefully imprint them on the back of our certificates. Everybody else rushed off and got jobs, and I thought, I think I'll take a bit of time off. So it wasn't until about February, 3 months later, that I rolled up for work at Royal Perth Hospital. And I started my work in the gymnasium there, which of course is a plum job. It's not too dirty, you don't have too much sputum and things like that that normally young graduates finish up doing. And started cutting my teeth, and it really was a valuable time to work with a couple of other senior physiotherapists in a close environment and have that mentoring process, which I think is absolutely essential even today, that new graduates learn to take the responsibility, but with the oversight and mentoring of others. And after my tour there of about 9 months, I landed the second most plum position, which was an orthopedics run. And I really enjoyed that. I got into plastering broken legs and arms and replacing plasters after the grand ward round on Friday morning. And there was one occasion where the surgeon pointed to a cast that had been applied that looked as though Lord knows who had made it. It was meant to be a cylindrical cast, but it was actually square in cross section, if you could believe it. It was lumpy and it was bumpy and it had no padding at the top and the padding at the it was awful. And the house surgeon said, that was mine, sir. And he just said, you will never do another plaster unless the physiotherapist is with you. So I took that as a compliment, at least to my plastering skills. And in those days, you learnt all the new gear was coming in. There was the cup arthrodesis was pretty new. Then the McKee-Farrer total hip joint came into place, and that was all the rage. And they worked. Obviously, don't work anywhere near as well as the prostheses today. But it was an exciting time where prosthetics, they were starting to get into the fact that they could control the tissue rejection issues. They had better metals to work with. They weren't into ceramic or anything like that in those days. But just the whole business of having a patient that walked into the hospital on crutches and in about 10 days, they were actually in bed probably 5 days before we were allowed to get them out, and we had progressive exercises and so forth to do. It was good to see, even in the time frames we worked in those days, to see the results that they were starting to get out of the total replacements of all sorts of joints. So they were exciting times. And I recall one of the surgeons, Mr. Roger Weeks, tall British man, great big mutton chop whiskers, little beady eyes, and he had actually studied under Syriacs, under James Syriac. So he was really highly influenced by Syriacs, and very, very progressive, to the degree that his cohorts, his other surgeons, really thought he was out on a bit of a limb. When somebody had a femoral fracture, for example, he put a traction pin through the tibia and made the hospital organise a bed that could split open. And after the first week or 10 days, we as physiotherapists had to come along, drop the bottom out of the bed and allow the full knee flexion to take place whilst the femur was healing. And of course, this was unheard of. Normally it was just stuck into a cradle in bed and left there for however many weeks they thought it was going to take. Consequently, these patients actually got better faster once they were into the rehabilitation stage. So it was exciting to be involved in that sort of atmosphere where somebody really wanted to push the boundaries a bit. And I remember Mr. Weeks again at a outpatients clinic, and a young boy, I guess he would have been 12, 13, had a badly fractured elbow. Not a good joint to fracture under anybody's books. And he was all plastered up and so forth from the weekend from the A&E clinic. And he told the nurse in his first examination, go away, bring the boy, take his plaster off and come back and see me. So about half an hour later, the boy came back into the clinic with sitting obviously at the side of the table, and he looked at the boy and so forth and started moving it, and the boy was wincing a bit. And he stood above me. I'm fairly tall, but he towered over me, and his beady little eyes bored into me, and he said, I want you to take this boy away, and every day I want you to bend his arm somewhere between his wrist and his elbow. And I don't care where, but make sure it bends. And this was his approach. You know, obviously the elbow was so smashed that to get a nice anatomic healing of the bone there was fine, but the elbow would never move again. So he was quite happy to go for a pseudo-arthrosis, is it? And get some function going. So he really worked on function rather than an anatomically nice x-ray that wasn't of much use to him. So again, it was an interesting experience to have this sort of attitude. Let's get things going, let's get things moving. And he obviously was hugely pro-physiotherapy and supported us as a profession the whole time. It was good to have that sort of support. Whereas the others, of course, I don't know about orthopaedic surgeons now, but, we'll wait 6 weeks and then we'll see about physiotherapy. Well, of course, there's improvement in 6 weeks, but it could have been an awful lot more improvement had we got onto it earlier. So this guy certainly worked on that principle.